Hello everyone, my name is Rachel Moses and I'm a consultant respiratory physiotherapist and I'm currently working in a Chief Allied Health professional role. And I'm delighted today to be joined by three amazing physiotherapists on this sunny Sunday afternoon, bank holiday weekend, to talk about all things post-hospital discharge, COVID, community, rehabilitation and physiotherapy. So for those of you that have been listening to the podcast so far, we've very much focused on the acute needs of these patients, ICU, ward management, everything from the ED to discharge, how we manage these patients in preparation for discharge and some of the tools we have. But what we haven't really talked about is when these patients go home and into the community and what we need to be looking for. And part of that is because we have only really started over the last couple of weeks to discharge huge amounts of numbers, big numbers of people who've been sick enough to come into hospital to be, in that discharge pathway. And now we've also been caring for people in the community what the needs of these patients are. So the obvious disclaimer is that the three people I'm going to introduce to you, this is all their personal viewpoint. They're not saying it's the right or only way to do anything. They've been very brave coming on. They're just normal, everyday clinicians who are experts in their field and who have a lot of experience. So I'm really, really grateful for them to talk to me today. So my top left is Ursula Freeman, who is a team leader in community pulmonary rehabilitation at Sheffield Teaching Hospitals NHS Trust. To my bottom left is James Lendon, who is a clinical lead physiotherapist for Calderdale Pulmonary Rehabilitation, and that is in Calderdale and Huddersfield NHS Trust. And to my bottom right is Cath, who is a clinical specialist respiratory physiotherapist, also from Sheffield Teaching Hospitals. So as I said, really grateful that they're here today. So I'm going to kick off by kind of setting the scene a little bit. So we've had a patient who's been unwell enough to need hospital admission, either to the critical care unit or they've been sick enough to be on a respiratory ward, and they've been discharged into the community. And Cath, I'm going to come to you first because you've actually been seeing these patients in the community. You've been seeing some of the challenges that we have treating these patients and some of the needs that they have. So do you want to tell us a little bit about your experience so far?
Hi there, thank you very much, Rachel. We've seen a number of patients now in the community, and we've recently done an audit and trying to capture the presentations that are coming through to us. And we're actually seeing a number of things from cardiac presentations to neuro, things like dizziness and almost like a labyrinthitis, kind of people being wobbly. Some people with post-ITU myopathies, such as painful feet or numb feelings in their feet. And obviously the post-pneumonia symptoms that you'd expect, which are the breathlessness and things like that. One big thing that we're seeing is oxygen desaturation, which I think we're going to be covering later. But we're seeing about 71% of patients have got some significant oxygen desaturation. So that's quite a high proportion of our patients. And the age ranges, we're seeing people from 50 to 94, and normally in ICT therapy, we might expect to see the older population needing aids and adaptations. But particularly at the moment, we're seeing people of working age who were working up until the point that they got COVID, and people who were abroad. So people may be a little bit older, gone on holiday and picked up COVID there and was tested before they got back on the plane. So we've seen a massive spectrum of age, and also people who may have had comorbidities to begin with, some more serious than others.
That's so interesting, and even those statistics you have from like what is essentially a single centre is fascinating. So we have all managed post-viral kind of fatigue, and we are going to do a separate podcast on that. And we've all seen these post-discharge patients who can have debilitating breathlessness after a severe pneumonia or viral pneumonia for a couple of weeks, 3 weeks, sometimes even longer. But this population of patient, like you said, they are a younger population of patients with a lot of them having no existing health complications. And I think that's the thing that's really challenging here, isn't it? Because they're a population of patients that should never really need to access rehabilitation after a hospital admission. And we know that most centres don't have a rehab pathways already set up for even ICU patients that are going home. So now we have this whole other patient population that we could never have predicted that would happen, that there's no actual pathway for them. So that kind of leads me on to my next question, in terms of follow-up from hospital. So Ursula, if I can bring you in at this stage, there's a lot of people going to be discharged from hospital that have rehab needs that, there is no pathway for them to go into at the moment. So if you're the physiotherapist in that acute ward that have seen the patient, like Cath says, in that acute phase, what kind of mechanisms are there to refer your patient in post-discharge already? Like what if you think this patient's going to need follow-up, I can't just discharge them home. How do people do it?
So currently in Sheffield, and I think this is a nationwide thing, is we have a single point of access, a SPA facility, so people can ring one number and describe what kind of rehab or service that they require for their patients, and they can be signposted to that service. So that's the usual method of referral, and it works quite well. What's happening now, and I think it's something that's been suggested nationwide and that Sheffield are taking on, is a screening process. So what we're trying to do is to contact every patient who is post-COVID, not only those who have been in hospital, but those who have managed their illness at home, and assess their needs. And this will be a team of clinicians from the acute trust, the community trust, from GPs, from the mental health trust within Sheffield. So it's looking at a very holistic approach, trying to match up the patient's needs with the services that are out there.
So that sounds perfect, and that sounds perfect for every patient actually who has any kind of need, who's discharged from hospital, that it's a needs-based assessment. I think one of the things that's slightly frustrating, and I know we'll come on to that maybe when we speak to James in a bit, is pathways starting to become developed about a disease, and about, oh, you've had COVID, so you need to go into this pathway which you will access this, and that works really good for some population of patients. Like the best example would be COPD patients going into pulmonary rehab. Yeah. But actually, like you said, there's needs of these patients that exist depending on the problems that they've had in hospital. So this needs-based assessment tool that you're describing sounds ideal. And is that something that is being designed nationally, or is that something that's just being designed within Sheffield, or could anyone just access this?
As far as I'm aware, it was been nationally recommended. I think it was through the British Society of Rehabilitation, was suggesting that there needs to be some kind of pathway for following up of these patients, because I think that's been an issue at the minute. There's lots of people who have already been discharged from hospital that haven't had their rehab needs met. And I really think that, we need to look at the existing community services that are out there. And in fact, they cover a whole range of needs. And I think this is where community services are going to come into their own. In fact, the services do exist already. And what we need to do is showcase them really, and saying, look, this is what we can offer. And it's not just physio, we're talking OTs, talking speech therapists, the dietitians, the mental health services. And I think what we need to encourage is the collaboration of those existing community services to say, these are the particular focus that this therapy team can offer. And it might suit one patient, where there might be a different therapy team that can offer something else to another patient with different needs. So we all have our different focuses. There's some overlap as well, which is really useful. And hopefully that helps when you're referring a patient from one service to another. But I really think this is our time to showcase what community can support these patients. And I know for years the ICU physiotherapists have been screaming out for this post-ICU recovery pathway. We don't have one in Sheffield, and I know my colleagues in ICU have been desperate for us to take their ICU patients into pulmonary rehab, but it's never been commissioned. And I think maybe this is the time that maybe people will start listening and saying, we need this.
And do you know, I think everyone would agree, and everyone would agree with everyone that leaves hospital with a therapy need or a rehabilitation need, access as a pathway. But even if we had, I suppose, even if the commissioners agree to that, A, it needs resource, it needs financially funded, and B, we don't have this magic workforce ready to go. Or do we? Do we have a group of therapists just waiting there ready to slot into these newly commissioned rehab pathways?
I think we do, but I think there's an issue with balancing it between our regular cohort of patients, our normal work, and this new cohort of patients. And that's where the issue is about resources. I think the skills are there. I think we need the resources in terms of more staffing. And I think what was interesting when I was deployed into the acute hospital for a few weeks just before Easter, when we were expecting the surge, a lot of community staff were sent into acute services. And I remember thinking at that time, at some point, is it going to tip the other way? And is it community that are going to need those extra members of staff to support this ongoing rehab? And maybe this is the time. I don't know.
Agreed. And I'm going to pick up that point in a minute with James. But for now, I'm actually going to move back to Cath. And Cath, before we think about the specific rehab, you touched on a couple of really important points in the opening when we're setting the scene about what types of patients we're talking about in the community. Let me just pick up first about the desaturations in these patients. So the obvious ones, the ones that are breathless on any exertion will have exertional breathlessness and desaturation. Can you just talk a little bit about why that happens, a little bit about the physiology, about what's different maybe in COVID?
We're actually getting people that are desaturating significantly without massive levels of breathlessness as well. So what we would term happy hypoxia. So I think probably once people have been into hospital, they're coming out and the resting saturations might be okay. But even minimal exertion, we've been finding that people are desaturating. For example, we had a lady who desaturated to 79% and took 20 minutes to recover, having just walked 3 meters to the bottom of the stairs, and she didn't feel massively breathless. So that's very different than we would normally see with a fibrosis patient, for instance. We'd normally see somebody with fibrosis that may or may not have the breathlessness, because some people have a less response to that, but we'd certainly see a quick recovery with somebody with pure fibrosis. What we're seeing is the cardiac implications in terms of the recovery and the payment of the oxygen debt that's caused by this. So there are a couple of things within that. One is that the level of desaturation is much lower, and that goes back to the whole pathway and the pathophysiology of this. So if we think about how SARS gets into the lungs, it attaches to the ACE2 receptors, and that can cause inflammation in the lungs, and it can lead to what's known as a cytokine storm. Now, that has numerous effects. One of those things is it can affect the ACE2 receptors in the heart as well. And between the immune response and the cytokine storm, that can cause myocarditis and myocardial damage. And what can happen then is myocardial dysfunction, which leads to arrhythmias, and we can get higher troponin I levels, which again can cause the myocarditis and the myocardial dysfunction, leading to the arrhythmias as well. We can also get heart failure, and that lack of cardiac output is something that we're seeing in patients with the COVID, post-COVID, in those kind of low functional rehab levels. So we're talking about people that are currently housebound, that might just be trying to do transfers, trying to walk to their stairs. The biggest desaturations we've actually seen is on the stairs. And the reasons for that is that people are doing more than they might have done in the hospital. Because of zoning, they might not have done the stairs at all in the hospital. Because they've been in a side room, they've never actually been physically challenged. So they're coming home, and possibly for the first time, they're doing things that they might not have done before, and more frequently as well. So they might be using the toilet, they might be going to get a meal or something like that. And those little things are having an added on effect. So normally in terms of oxygen debt, you'd rely on your muscles to kind of repay that debt quite quickly. But if you've done something beforehand, the oxygen debt hasn't quite been repaid. So your oxygen debt is repaid by things like improved cardiac output, and we're finding that people's heart rate isn't actually responding in the way that we would expect. We'd expect somebody who is desaturating, would expect their heart rate to increase, and we're not always seeing that. So it's all that picture can lead into somebody who's desaturating for quite a prolonged period of time. Now, normally what we're saying, if somebody's desaturating a little bit and they can correct that with pacing, we would stay to focus on functional resistance exercises, which can improve your oxidative capacity. For people that are desaturating to a significant amount and it's taken a prolonged amount of time, that needs addressing. So we've got a really good network of support in Sheffield with our consultants and with our oxygen team as well. So for those patients, we can take them to the virtual MDT, we can speak to the oxygen nurses about having an increased prescription of oxygen as well for exertional purposes. Now, these people don't meet the usual criteria for oxygen desaturation. Normally, if we had somebody who is significantly desaturating on exertion, we'd send them to PFU. They'd have a 6-minute walk test, and they'd have to be leaving their house, and they'd have to be able to carry the cylinder or be able to use a trolley. Now, these patients aren't leaving the house. They're doing very minimal exertion, so they're not eligible to have that 6-minute walk test. They wouldn't even cope with it. So we're looking at things like how many sit-to-stands can people do in a minute and things like that to be able to see what's happening. Not all our patients can even sit to stand, I hate to say, because of their balance problems. So there's a lot more things that are implicated with this, and it takes a lot of that MDT approach to be able to find out what's the best approach for this person. Can it be addressed by pacing? Can it be addressed by resistance exercises? And is supplemental oxygen necessary? And what cardiac things are going on with this patient that need further investigation? We've only touched on that a little bit. We've also got the endothelial things that are going on. So the microvessels within the lungs are affected. And normally what we find is that you have a VQ match where the ventilation matches the perfusion. So the oxygen coming in can get picked up by the blood and get circulated around the body. And what we're finding in the COVID patients is that there's levels of hyperperfusion because of the endothelial damage in the cells. So you've got blood being perfused to areas where there's pneumonia damage and pneumonitis, and actually there's a vasoconstriction where the blood isn't getting to areas of the lung that is ventilating properly. And on top of that, the endothelial levels in the arteries are being damaged as well, and you're getting plaque instability. So we're finding a high level of PEs in this population as well, and that is exacerbated by high levels of fibrinogen and also increased levels of coagulation within the blood that's caused by the inflammation processes as well. So there's a perfect storm for people with lower mobility and people with higher risk of PE as well. So what we're finding is that we are picking up PE in the community. So that's something that we're trying to get people to monitor saturation and monitor for PEs as well, because those things are happening and we're seeing that in clinical practice. One of the other things that we're asking to monitor is not just saturations, but also cardiac rhythm, as well as the cardiac rate, because we know that the arrhythmias can happen and those are exacerbated by hypoxia. Those two things are happening. You've got the arrhythmia from the cardiac damage and the arrhythmia as well from the hypoxia. And also you've got the PEs and the coagulation that is exacerbated again by hypoxia. So monitoring those kind of things is really important. So we had one of our staff picked up a PE most recently, and the symptom was a fluctuating saturation rate, and that person got readmitted and did indeed have a PE. So looking out for fluctuations in saturations is really important as well, because not everyone's getting the chest pain that we would associate with PE, but the risk of PE is high, and you might see it in things that you wouldn't expect to find. So monitoring is the thing that I have to stress is the most important thing, and communication is the other thing to make sure that gets fed back to the team.
Right, and coupled in with that is all the skeletal muscle problems we're seeing as well, isn't it? And some of the diaphragm dysfunction, and which can potentially mask some of these problems. Now, just a quick question on the oxygen. I know Ursula wants to come in as well. Is one of the big questions is how low is low? So the majority of these patients nationally aren't being discharged with oxygen. That's what we're hearing. Then they're being reviewed in the community to some degree, and the physios are picking up and community nurses are picking up low oxygen levels. So how low is low? How low does low need to be before you're concerned, before you're picking up the phone and saying, I think this patient needs admitted, or I think this patient needs emergency domiciliary oxygen? Like you said, they are being prescribed short burst oxygen therapy or ambulatory oxygen therapy where they would normally not fit the criteria for. So yeah, what's your advice there?
I think that there's a couple of things in there that we've kind of touched on before. One of the things is that it's not being picked up in hospital because patients aren't doing their normal level of exertion that they would have at home, and that's partly because they not wanting to risk staff being in contact with these patients in the hospital, and partly because the patients are in a side room and haven't got access to stairs or a normal walking distance that they might normally need to go to the toilet and things. So we're finding those things in the community where they haven't been picked up that they need ambulatory oxygen. Whereas I think if the access was better in the hospital, those things might well have been picked up and they might well have been discharged with it. And that might vary from hospital to hospital as to what those circumstances are. For us, we would go with the normal prescription for ambulatory oxygen, which is if somebody desaturates below 88% below 90% by 4%. So somebody who's desaturating from 92 to 88%, we'd have to have a think about that. We would flag all those patients up with our oxygen team and the respiratory team, but it might be something that doesn't need to be addressed by supplemental oxygen. If that person can pace better and if that person can manage with the resistance exercises, it might be that the next time you see them, the recovery process has taken place and they might not be in that situation. And that's what we're finding, that the lady that desaturated to 79% the first time only desaturated to 90% the second time we saw her. And that's simply because of what she'd done beforehand, in terms of when we saw her. Before we saw her the first time, she'd been trying to clean the house. The second time she hadn't. And it's about that pacing of activities as well, is that you might go and you've only got that snapshot of when you see the person, and you need to build the picture of what have they been doing that day, because that might be the difference between prescribing them an ambulatory cylinder that they don't need the next time you see them, and you've gone through a massive process that the hospital staff didn't need, the patient didn't need, and you didn't need. So if the patient can get through that by resistance exercises and pacing, I would still flag it up with the oxygen team and the consultant, because there might be something else going on that needs picking up, but it might be that they don't. If somebody is desaturating to lower than 88%, and we usually have in our criteria even below 85, we wouldn't really want to be exercising somebody with saturations of less than 85 is our usual cut-off criteria in the community to look for supplemental oxygen. But what we're actually thinking of is, what are the comorbidities with this patient as well? Because we know that hypoxia can lead to arrhythmias. And if we know that the exertional recovery time is quite prolonged, that might be having more of an impact on that patient. So they might need the supplemental oxygen at higher levels. So they might need it at the 88, they might need it at the 85. But certainly we're seeing people that are desaturating into the 70s, and we would say those patients would definitely need it. The majority of these people are type 1 failure. So our consultants have said to us that we can increase the oxygen to 4 litres a minute for their exertional, and that if they've got an oxygen concentrator in the house, we can do it on their oxygen concentrator. That isn't the same for everybody. Some people won't have that resting oxygen need, they won't have a concentrator, and they will need a cylinder. But we've been told that generally the picture that we're looking at without a PFU assessment is that we can increase oxygen as needed up to a level of 4 litres, but that'll be different between each hospital. But I would be saying we need to be looking at the cardiac causes of this as well, and that may need blood tests, or it might need some further investigations as well for the people that aren't recovering quickly. And I think I've covered everything there. I might jib in with some.
No, what about this silent hypoxia? This is another question that keeps coming up.
So happy hypoxia is something that has often come up where people haven't been admitted to hospital because they've thought they were okay. And then they've had the drive-through test and somebody's put the SATs on their hand and they've realised that they've been quite low. And certainly some of the reasons for admission has been they've been borderline at rest, but then when they've done minimum exertion, the SATs have plummeted. So they've not had that feeling of breathlessness. Now, if we think about normally, our normal response to it's for breathlessness, is our trigger is carbon dioxide. So if you were to hold your breath, or I was to hold my breath, the thing that would stimulate us to breathe would be the carbon dioxide. But these people have got low oxygen levels, and they haven't got that feeling of breathlessness, because the diffusion is different for carbon dioxide than it is for oxygen. It's harder to get in oxygen into the blood than it is for us to get rid of carbon dioxide. So our carbon dioxide levels may well be normal, but actually our oxygen levels are very, very low. And it's this thing that people don't often have a grasp on. So they might, and that's where pacing comes in, about pacing activities, because you might not know how low your oxygen levels actually are. And we're saying it has different impacts depending on what your comorbidities are, and also on the duration of recovery.
Thank you very much. Ursula, did you want to come in with a point there, or have we covered?
Yeah.
Sorry, it was just, Cath, I just wanted to reiterate, you were talking about fluctuating oxygen levels with PEs. That was fluctuating at rest, wasn't it?
It was. So we had somebody who was a case that was desaturating at rest, and the sats were going between 91 to 94, I think. There was quite a big range. Sorry, did I say 91? I'm at 88 to 89 to 94. So some people would have said, you know, that's okay, they're 94 at times, and that's all right, and wouldn't have seen that. But because we'd done a webinar with the staff the previous day, I think, and said, look, these fluctuations can be a sign of PE, they readmitted the patient. They spoke to a registrar in the hospital, readmitted the patient, and that patient was found to have a new PE. So we're saying that, you know, try and look out for that. The fluctuating sats can also be a sign of arrhythmia. And we're saying to people, make sure they're doing heart rhythm as well as heart rate. And that's the thing that's often missed. And when we're taking heart rhythm, we're looking at a period of minute to be looking at a heart rhythm. You know, sometimes it's easy to pick up on a blood pressure. You'll hear that the heart rhythm's a bit all over the place if you're not confident about feeling it. But if you're not confident about taking those obs, we'd certainly recommend that you get trained up to do so.
Thank you very much. So, James, you've been waiting really patiently there. Thank you. So that was such an in-depth, incredible summary. Thank you, Cath and Ursula. So we have these patients who we know are complex. We have these patients that we know are challenging. They have oxygen deficiencies. They have cardiac involvement, huge fatigue, malaise, tiredness, sleep disturbances, probably some post-traumatic stress or the psychology around COVID. They then are developing these weird neurology type presentations on top of that. And they are socially isolated. So a lot of these patients may live alone. These patients may be living with older members of family or may have no real support network. We talked extensively about the nutritional deficits these patients have as well, and getting access to good food is a challenge for some people. So James, it's very obvious that we can't just expect any kind of therapist to go out there and look after these patients without having all of the skills. And sometimes it's just having that gut feeling of, isn't it, as a respiratory therapist, whether you be an OT, a physio, a nurse, about having that gut feeling of how to manage these patients. And I know that you normally would work in pulmonary rehab, but actually you've been involved in some of the rehabilitation planning and follow-ups for COVID patients in the community. So do you want to tell us a little bit about strategies that we may use, things to be aware of, and maybe some rehab pathways that could be beneficial for these patients? I know that's a lot in one question.
I mean, I think just to kind of evidence what I've been doing, as most people have been doing, I've been redeployed, and I actually myself have a critical care background, so I was back on the front line in critical care. But one of the things that I did identify is early on is, as I think Ursula said as well, that change of that movement from acute care to community. I saw it coming and see it coming. So then you're like, I'm in critical care. I need to get back into community now because these patients are going home. And I think one of the things that we were talking about is there's these pathways that are out there, this information that is coming. There's so much coming out, dribs and drabs from different places, different journals, different societies, etc. it's very hard to keep up, as we were saying before, about trying to keep up on what to look on, what to read and what to see. And what I would say is the good thing I think that's come out has been that there is a lot of consistency in relation to getting rehabilitation for these patients. And one thing that I've noticed, because I'm like Cath was saying, I'm out there and seeing similar presentations to what you're seeing, and you do need those specialist skills. But I've actually also been tasked to identify for people who aren't necessarily working in these areas, like you said, that maybe the MSK physios have been moved from other areas, other rotational staff. What kind of things should we be looking at? And I think as respiratory physios, we're great to guide these people. That's essentially what we're doing here today, I suppose, isn't it? What I was mentioning before, I know the British Thoracic Society have come out with some guidance, and I quite like the fact that they discuss a holistic approach to assessment. So a bit of a, this is what should be done for patients post-critical care with COVID. And that's my kind of background. It's the post-critical care ones. These are the pool ear end ones. The BTS do split between the kind of acute ones, the ITU ones, the respiratory support ones, and then also the ones that are further on down the line, the mild to moderate ones. My interest and my focus at the moment is on obviously the post-critical care ones. But there are 8 points that they make in the BTS things that I actually think that respiratory physios are definitely in the best place to actually address. So they talk about the assessment and management of breathlessness. Well, that's our bread and butter, isn't it? They talk about palliative care management and symptoms. Well, I know not necessarily, it's not something that physios are always comfortable with, but there's respiratory nurse support and other MDT members who are comfortable with that. And we've got close links with that. Certainly we do in Calderdale. I know we've mentioned assessment and management of oxygen requirements. We've just discussed that. We've got the same things, Cath, with you in relation to the difficulty we have, though, is I've been going off the same 4% like we would normally talk about, or that drop. But some of the consultants in the hospital are always variable on that. Trying to get some consistency with our consultants is very difficult, and I'm sure everybody finds that. So actually, I've been falling back on that 4% one as well, because at least that's in national guidance. But we actually would put oxygen in if we needed it on our patients. We've not as yet, because of that similar kind of thing. We've been working on functional pathways. Another point is the consideration of rehab needs. Obviously, that's what we're doing in our assessment. Psychosocial assessment, going back to the single point of access thing that Ursula was talking about, there are referrals that can go to occupational therapy to help with a lot of things around psychosocial assessment in relation to cognitive issues that are quite common with this, and fatigue and pacing and management. So I'm getting to work closely with the OTs in our trust. And I've also, in relation to anxiety and that kind of psychosocial thing, we have building links with our improving access to psychological therapies. So the mental health teams, being able to build a pathway with those. I think that's something important that I think most trusts should be building into part of their pathways if they can. And then you mentioned as well yourself, Rachel, dysfunctional breathing as a bit of a side onto the anxiety side of things as well. We actually have that as an outpatient. My team don't do that, but obviously identification of it is great for someone in my team who can identify that with respiratory patients. The only thing that we probably do struggle on, I think, Cath, you were talking about, obviously there was the VTE risk, and having a way for people in the community to identify these short of the normal, the saturation problems. But is there any other things that we could use out there? And that's something I'm trying to discuss with the consultants.
Okay, I think Cath,
in here, Rachel.
Cath's coming in here. Yeah.
Sorry. One of the things in Sheffield is everybody who's been discharged with COVID should be given anticoagulants for 30 days follow-up, and if they are significantly reduced mobility. And of course, I work with housebound patients, so they are all significantly reduced mobility. So we would expect that the majority of people should be on something like rivaroxaban or apixaban. And what we're finding is that not everybody is. Now, there's sometimes a good reason for that in terms of contraindication to an anticoagulant, whether it's a frequent faller or they're on another medication. But it is something that we're more concerned actually about the patients that didn't go into hospital that have got the COVID, who have never been on the anticoagulation as well. So that is one thing that all our therapists are looking at now, is the person on anticoagulation, and if it's not, we're flagging that up with the GP or contacting the hospital team who the patient was under, just to make sure that it's not been missed. So that is something that we're screening for.
Yeah, that's something I think that I'm looking to pick up. It's only just something that's come around in this last week or so for ourselves. And like I say, these patients are coming home and we haven't got something out there, have we? So it's a case of just building onto the pathway week by week, and that's essentially what we've been doing.
Okay, that is really valuable point. Thank you, Cath and James. So I'm going to throw this in, and I know I kind of didn't prep you for this a little bit, but I'm a massive fan of digital technology. I'm a massive fan of virtual, reviews, remote monitoring. But actually, from listening to you three talk, there is significant challenges with that for this patient population. So I know the bigger centres that maybe have really well-established ICU pathways are talking about a telephone review at 2 weeks. The patient self-assesses their own needs, and then a follow-up review in 4 weeks in clinic, or either potentially in the community by the outreach team going out and doing oxygen saturations and things like that. So James, in your opinion, do you think a virtual consultation with these patients might be beneficial? Or do you think actually, when we're talking about preparing rehab services, which we'll move on to next, is the huge benefit of being face-to-face for everything Cath's just said? Or do you think there might be a bit of a mixture? Do you think there might be services should be thinking about remote and video technology as well as thinking face-to-face?
I think you're right. I think there is a mix. And I think because of COVID, it has attacked mainly the working age population, more so than we're normally used to dealing with. We're normally in pulmonary rehab, certainly used to see more elderly patients with long-term respiratory conditions. But this is addressing people with no problems and things like that. So, but by the fact of that, they're working, generally they're quite better in technology-wise. So I think there'll be a split between the two. I think of the patients I've seen, and I think it's those physios, as we like to do, we like to get there and see them, don't we? And if we can get his hands onto it, and I think that's a real challenge as a physiotherapist, to actually be able to translate that into a virtual world, as it were. But I do think that as we go on with this, and the longer we stay in this COVID scenario with social distancing, etc., we have to do something, and we have to change our ways. I think this has made a lot of people start to think that way, and I think we will probably end up going a lot more. And I think it opens an avenue up to other patients who maybe wouldn't, for example, have come to pulmonary rehab. We can actually access those patients that maybe we wouldn't want to do.
Okay, I'm going to come to Cath quickly, and then Ursula, I'm going to come to you. Just Cath, everything you've just said about the complexity of these patients, the desaturation, the oxygen demands, the silent symptoms, the happy symptoms. My biggest thing when I listen to you, and I haven't seen any patients in the community yet, so I'm just looking outside in, like the balance problems. If you're doing a virtual consultation and asking someone to do a sit to stand, and you're not there, and even the safety thing if something happens, is it something we should be considering, or is it a blanket? Actually, absolutely, with the 70% of patients that are being discharged from your massive centre, and you're seeing 70% of them having needs, is it something when we're planning, would need to be thinking about actually physically with a patient?
Yeah, I think we're mainly using our virtual consultations for people that haven't got COVID, who don't want us to come because they're scared of getting COVID. So we use System 1, which is an electronic record, and there's a feature within that called AirMid. So that allows us to do one-on-one consultations, and we're aware there's a lot of different ones depending on where you are. Even within our hospital, some people using Attend Anywhere and some Accurex and all sorts of different ones. But yeah, I found it very useful in terms of teaching adjuncts and things like that to people with bronchiectasis who are quite well aware. And I think we've had 2 bronchiectatics, one post-COVID actually, who had came out, and it was just a routine review. But actually, I think really from what we're finding more and more now, I would recommend a face-to-face visit. unless the patient's really savvy about self-monitoring and has their own SATS monitor. So in Sheffield, we're trying to get more SATS monitors for patients to self-monitor, and that would be a particular client group. For our more for our housebound patients, we have to go out. We're providing aids and adaptations, and part of that is a home assessment. And sometimes that can be done remotely via video if somebody's able to do that. But in these circumstances, the situations are so complex, we're finding that face-to-face is necessary for our patients. Now, not everybody's going to be in ICT and got housebound patients with functional needs. They're being referred to us for mobility. So you need to be having somebody there to help them mobilise, to help them get up, to help them transfer. And it does involve face-to-face. But actually in between those visits, the virtual consultation is there to be able to prompt with the exercises, the resistance exercises and things like that, because our capacity's increased. We have to meet that somehow. So it might be that we supplement those face-to-face visits with more virtual rehab.
Okay, thank you. So Ursula, coming on to you. So I want to move on to the planning side of it. So I want to kind of think about, you are maybe a community team leader, or you are fortunate enough to manage services across primary, secondary care. You maybe work in an integrated care system. What should people be thinking about now? Now we've heard about what the needs of these patients are, what should we be thinking about in terms of planning the rehab needs of these patients?
I think communication is the big one, isn't it? It's making sure that the people who are organising these screening assessments are aware of what services are already exist, and which of those services have capacity to take on this extra group of patients. And I suppose you can have algorithms or flowcharts to say, if the patient's got this need, then you're going to be looking at these kind of services. You know, there's not one service that's going to meet these patients' needs. You're going to have to use several over a pathway. So, for example, a patient that might start off in early supported discharge with a multidisciplinary rehab team to get them home. And that was the patient's goal, was to be able to function and live at home independently. 2 weeks down the line, their needs and their goals will be different. So it's knowing that a one rehab service will meet the needs at one time, and then you need to know who else you can pass them on to meet the needs of another time. And then, for example, a patient that Cath's team passed to our pulmonary rehab team was a patient that had been discharged, and Cath's team went in, did lots of functional stuff, put handrails out, did this, and was really, got them all set up, got the ambulatory oxygen. Now, 2 weeks down the line, her oxygen needs are reduced. This woman needs to get back to work now. So pulmonary rehab have now stepped in and started an exercise program, getting her muscle strength up and getting her aerobic capacity up, enabling her to be able to go back to work. So the patient's needs are going to change throughout their recovery, and therefore their rehab needs are going to need to change. So the people organising these assessments and screening needs to know what's out there.
And I think that's a challenge, isn't it? Because there is huge variance. If we're trying to develop a national policy or a national plan, there's huge variance within the communities at the moment. I work in London at the moment. Between borough to borough, there's huge differences. Now, I've just come from working in the northwest, where there was actually much little difference, because you tend to think about things across a integrated care system or in terms of a region. So actually, in terms of national planning, it's really difficult. So you might have a discharge pathway from even a big teaching hospital that has no services or very little services. The reality is that's quite unusual, isn't it? Like you said, it might just be that nobody knows what's out there if they don't have a single point of access team. So the first thing you're saying is, if you're the commissioner, if you're the manager, if you've been tasked with finding a pathway for these patients, understand what's out there. So I suppose finding who you can speak to within the acute hospitals, and then within the community services as well. And then the second thing is understanding that the patient's needs might change. So if you have a group of teams that currently maybe work quite fragmented or aren't collaborative like your teams are, how can that be challenged or improved, or how can we manage that? Is
a
it
good
possible?
question.
Is it
I don't
possible?
know.
And
I think it's something that we've always battled with, really, and I think, you know, it's all about communication and breaking down those barriers between acute trusts and community. I mean, in Sheffield, the primary care trust and the acute trust joined together about 10 years ago, and we still have communication problems. You know, we both use different IT systems, even though we're the same trust, and you know, there's limitations. And I think this is again, it's going to highlight the problems that we've had for a long time, and highlight the need that we've got to change it, and we've got to break down those barriers and stop being so precious about our services and share a lot more, like we're all doing, you know, on these kind of podcasts, and use each other for the patient. And this, you've got to put the patient at the center of this and personalize the care. But yeah, it's a really difficult thing, because you know, you don't know what's out there. Often, you know, if you're a physiotherapist working on a respiratory medicine ward, you don't know that there's ICT therapy or a neurological pathway that's out there, because maybe you've only been working in that trust a few months. So it's a really hard thing to do.
And I think you're right. We're in a time of change, and my experience, and James, you mentioned the MSK physios. Now, my experience of the MSK physios and all of this has, and I can't generalize here and say like 100% of MSK physios have done X, but my experience is that they have absolutely come to us as acute teams, whether that be acute community teams, acute hospital teams, and said, what can I do? How can I help you? MSK physios in acute, if they've just not long been off on call rotas and working in ICU, have been said, like, give me some refresher training, give me some COVID training, give us some PPE training, and I will go onto the wards. We will help you. Same in the community. So those MSK physios who maybe see acute neurological patients in either their social enterprise organisations or their private practices, have come and said, what can we do here? So the thing that I think the majority of teams don't do is have that communication between the acute trusts and the community providers. I think there's a distinct gap, and I don't think that's because it's an intentional divide, if you like, but I think that's how commissioning has made us. And I think when the commissioning kind of pathways change, that is why, because the hospital's just got a big lump sum money, and then the GP's got all this money, and then we had to apply for it, and then there was slight competition and who got what, and then you were only allowed to see patients within this set pathway criteria. And I think this is where the community rehab's challenging, because it's been built around disease specific models to some degree. So what you're saying, Ursula, is actually, let's just speak to each other, let's learn from each other. What is out there in your community? Where is the gap? So if we understand what the rehab needs of these patients are, everything Cath said, everything James has said, from working in acute to now thinking, actually, my gosh, we're going to have a real hard job in community here. You know, and I mean, are these patients being readmitted back into hospital? Are they developing? They were talking about COVID relapses. We've been talking about COVID exacerbations. We're talking about these patients who, like you said, James, who are normally fit and well and active, who have then suddenly just went for a 2-mile walk thinking, I feel amazing, but then within 12 hours they're completely floored again, and they don't get off the settee for 4 days. So in terms of what happens next, and I'm going to come to all three of you for this. So in terms of what happens next, we need to understand what is out there within our own communities. We need to understand kind of what the gap is. Now we've explained what the patient need is, and then we need to understand how we're going to resource that gap, which is the hardest thing, isn't it? At the minute, the COVID budget has been unlimited in acute. Ursula, you mentioned this before, is this COVID budget going to extend into community rehabilitation? This is the big push now from us, and the campaigns from the CSP and other organisations like the Right Care models are brilliant, and the Right to Rehab campaign that went to Parliament in February, there's been a massive push for community rehab. So what happens next? Start with you, Ursula, then I'll move around.
I can't answer it, Rach. I don't know. I don't know is the simple answer about what happens next. I think it's like with the whole of this coronavirus pandemic, is that we're learning as we go along and things are changing. We don't know, are we going to be still doing COVID rehab this time next year? Are people still going to have residual problems this time next year, or ongoing? Is it ever going to go away? I think it's completely unknown, isn't it? And I always keep saying we're just making it up as we go along. And in a way, we're trying to extrapolate from previous experiences and knowledge. But I don't know. I really hope that this experience can show commissioners and people that are in charge of the money what the allied health professions particularly can offer, and how we can adapt to suit the needs of these patients, but also that we can't do it on a shoestring. It's important. It's not all about the drugs and the funding and the money that comes with that. Rehab and therapy is so important. I'm just hoping that this showcases what allied health professions can do.
Thank you. So James, moving on to you, please. It's all right, you're on a mute.
Sorry. I think going on from just what Ursula said, we are making it up as we go along, aren't we? I, like probably most other areas, have had to put planning and recovery plans, as they're called, through to senior management as how we're going to do it, and it's all very much just like, well, if A happens, then we'll do this. If B happens, we'll do this, and it's like a smorgasbord of kind of choices for people. My thoughts are that I did wonder about this, is that whether, certainly from a pulmonary rehab point of view, whether, like I think Ursula mentioned before, actually, do we have like a separate cohort of patients that we accept into rehab that have almost like a post-COVID lung, as it would be? We obviously still we have interstitial lung patients, and we have pulmonary hypertension patients within pulmonary rehab. These seem to be the main themes that are coming from that. So that might be just a different way of working. Now, how we do it, whether it's virtual, whether it's face-to-face, that's something I think we will never know. But I do think that we have to use this opportunity, again, like Ursula said, to expand our services and move the community teams while they're maybe not doing their work. I mean, I'm certainly, I've split half my team. A couple of us are doing the post-COVID work, while the other half are doing looking into the virtual side of things. That might be how it is. It might be that I have a split team and we do two types of work. I don't know.
Yeah, and I think that brings the great point that Ursula made about the needs assessment for the patients, and actually, it's not just a post-COVID thing. It's based on all patients that may have needs leaving hospital, and we'll redesign my rehab pathways on that rather than disease-specific pathways in the future. The PR thing is going to be such a hot potato topic, like in terms of, do we go down that model, do we not? I think if there is a podcast on that, I think it would need to be chaired very well. So I'm going to move on to you, Cath, in terms of your thoughts on that.
Hi there. I echo really Ursula and James there. I think there's a lot of teams that are already in place, and it's about communication and working together to have the best plan. So we're lucky, say in our team, that we do have mental health support, we do have OTs, and in the other services around as active recovery, they've got access to the dietitians and speech and language therapists as well. So it's about using that whole MDT. Ursula would kick me if I went for the whole podcast without mentioning inspiratory muscle training, which is one of my favourite topics. But it was quite interesting. I was reading today about one of the things they found out from SARS was that in the follow-up, that inspiratory muscle weakness was far more common than fibrosis. And I think that that is something that hasn't really been touched upon. We're talking about pulmonary rehab and the cardiovascular exercise and resistance exercise, but we haven't really touched on inspiratory muscle training and its role within COVID recovery. And I'd be really keen. I think we're going to be starting to use that. Certainly one of my colleagues, Sarah Lee, is looking at a proposal just to try and get that a little bit of a more robust proposal coming back from people, particularly if they've been on ICU, who may experience that inspiratory muscle weakness at a greater proportion.
Mm-hmm. No, definitely, and I think that's something definitely to link up with Rick and Bernie about, because when COVID all started to manifest, if you like, I remember very early on they both strong advocates for inspiratory muscle training and said this will become more evident post ICU, particularly when people have been ventilated for weeks on end, not just as the result of the pathophysiological consequences of a respiratory virus, but coupled with proning, like everything. So yeah, interesting. Definitely not an area of mine, and I definitely think there's two sides, two camps, isn't there, when it comes to inspiratory muscle training, but I think you're definitely right there. I think there is going to be a role, and there is going to be patients who have inspiratory muscle deficit for sure. You've maybe opened up another podcast there, I don't know. So I just want to finish by saying thanks so much to everyone for participating today. You've been amazing. There'll be links to some of the things we've talked about on the website underneath this podcast. And thanks again for your time. Really appreciate it.